try to get started right on time. We are so fortunate to have Joe Musso here with us today, member extraordinaire who's always willing to help. Today he's going to share with us his knowledge on nursing home litigation, which he is very, very knowledgeable on, a wealth of information. So just a few housekeeping things. I'm going to go ahead and mute myself so I don't distract. Please do not press the share screen button at the bottom of your screen. That's only for Joe. I think we all know that now that we've been doing Zoom a while, but there's always sometimes that problem. So I'll just keep you on mute. You can put your video on or off, it's up to you. And then if you have questions, go ahead and use the chat function down at the bottom. If you hover down at the bottom, you'll see the chat function. Just know that there's the choice of going to everyone or just to, if you want to just ask me something specific. But what we're going to do is let Joe do his presentation. And then if we have questions, he is definitely going to make his time available for us to have questions. So you can either indicate you want to ask that out loud and I'll unmute you, or you can just ask it in the chat and I will speak on your behalf. So without further ado, I introduce to you Joe Musso. Take it away, Joe.
Mary, thank you so much. I really appreciate the introduction. I had the benefit of actually looking and seeing all the participants here, and I can tell you that good 60% could be teaching this class. So it's nice to see so many of my friends and so many people that I know are struggling with the same issues that I'm struggling with in my practice. For the few of you I don't know, as Mary said, I'm Joe Musso. I'm the head of nursing home abuse and neglect litigation at Ashcraft and Jarrell. And I have spent my 23 years in practice representing the institutionalized elderly in abuse and neglect litigation, and that's nursing homes and assisted living facilities generally. So I've got about 30 minutes. Again, I'm happy to stay as long as I need to answer any questions you have, but I will tell you up front, the reality is here we are a few weeks, month, 2 months from the beginning of this outbreak, and the reality is I have more questions than answers for you today. I think one of the goals that I have is for you and all of us who practice this work or want to practice this work to help you kind of orient your thinking on a variety of fronts. The really short summary of all of this is COVID is ripping through our nursing homes. It is going to kill a disproportionate amount of nursing home residents relative to the rest of the population. A significant portion of those deaths will be avoidable had the facility not been negligent, grossly negligent, or reckless. And those terms are going to become more and more important because I believe that we are going to see massive sweeping immunity against nursing homes as a result of this. And we do have some sense of where we are currently, but I do think it's definitely an evolving situation. I'm going to try to give you an overview of Virginia, Maryland, and DC immunity at some point here. I see we've got people like Chris Nace on participating here who may have even more answers than I do with regard to DC and where it's going. But I'm going to talk to you about all of that. And I think really the most important thing is to remember that regardless of whether or not there's going to be immunity for COVID cases, whether there's going to be immunity that every defense lawyer is going to be sneaking into non-COVID cases, and the short answer is they are. COVID is going to change the way we handle cases, well, for most of us. And I'm going to be real specific with you at the end here on how I think we have to, if we're not already doing it, how we have to really commit to a certain way of prosecuting these cases if we're going to be successful after this outbreak. So without further ado, let's move along a little bit. I'm going to give you just a little bit of background. I mean, you'd have to be under a rock and not sitting at home, working from home and watching television 20 hours a day like the rest of the world to not know that the virus first hit the United States in January. It hit its first nursing home in February, or at least the first known case. We're actually learning now, as recently as this week, that it was probably here well before the documented cases, which poses a whole other set of problems with some of the statistics and facts I'm going to be teaching with you, sharing with you. So I think it's really important, though, that we kind of, what seems like 6 years is actually only a few weeks. But the beginning of this, if you recall, we saw people partying on beaches in Florida, and we didn't say, oh my gosh, how are we responsible because they're going to get sick. What we said was, all those kids on the beaches in Florida are going to get someone else sick. And the someone else we were talking about are the immunocompromised, the elderly, and those with underlying health conditions, which is every single nursing home resident. It was January before the discussion started making mainstream media that nursing homes are going to be disproportionately hit. And it's true. And in this Wall Street Journal clip that I've got in this slide, our death rate topped 10,000 last week in nursing home deaths. And I will tell you that's over, that was a quarter of the deaths at the time in the United States. And I'm willing to bet any amount of money that that is grossly underestimated. Residents die in nursing homes from pneumonia, from heart attacks, from all of the things that people die from COVID. So COVID isn't necessarily killing residents. COVID causes someone with an underlying heart condition to have a heart attack. COVID causes someone with underlying diabetes to have massive endocrine problems, kidney failure, organ failures, pneumonia kills residents. Well, if that death certificate says pneumonia and no one gave them a COVID test, there's a good chance that they're not counted. I would imagine that the numbers are way higher than we're seeing. And even with the numbers that we're tracking with the limited number of testing that we actually have, and certainly that we had in the beginning of this, 25% of the deaths is scary enough. So just to give you a brief timeline, just to touch on it, December 31st, the first reported cluster in Hubei province. The week of January 5th, the novel strain of coronavirus is identified by WHO as being transmissible, person to person. The first reported case, January 21st, and the first nursing home case in Kirkland, Washington, at the Life Care Center in Kirkland, was on February 28th. One day later, we had our first nursing home death. In that same period of time, if you look at the way this is kind of jumping, what March 20th, 400 nursing homes had a positive COVID case. April 14th, just 3 weeks later, 23 nursing homes spanning 37 states. And now, weeks later, I don't have the data yet, but it's well over 5,000 nursing homes. That represents about a third of the nursing homes in America are currently struggling with it. And again, this is identified by testing, reportable stuff. I think it's probably grossly underestimated. Speaking of our jurisdictions specifically, what's really interesting is you're seeing this pushback from governments that are not wanting to identify facilities with outbreaks. They're fine with giving us general data, like Virginia as of April 21st says there were 80 facilities, 939 cases, 77 deaths, but they're not really telling us where they are, and they're not telling the residents necessarily where they are. And this is becoming problematic for a lot of my clients and a lot of the families of residents who are still, believe it or not, going into hospitals for strokes and heart attacks and other things. That hasn't stopped because of COVID. So they're going into a nursing hospital, they're getting treated for a broken hip from a fall at home or a stroke or a heart attack or whatever, and now they need to go out to rehab. The first question every one of those people want answered is COVID there? And they're getting really hard time getting any answers about that. Maryland has some massive outbreaks. The Future Care outbreak is just ravaging that facility. DC, and my date is a little old. It's as of April 15th. There were 108 positive cases in nursing homes and 9 deaths. I'm sure it's significantly higher than that at this point. And so I think what I want to kind of transition into is this discussion about a myth that you're seeing in the media a lot. And I think it's going to ultimately tie into the discussion about immunity that I think all of us should be versed and ready to discuss if a reporter were to call us, or if a client were to talk about it, or if a judge eventually wants to discuss it with us. That in the context of nursing homes, infection control of airborne illness, person-to-person transmission is not new. And the narrative, unfortunately, out there is that this unforeseen, horrible, invisible enemy has attacked 4 nursing homes who had absolutely no idea how to deal with it. And I don't mean to be cold, and I obviously will be very careful about how I say this publicly, and I have been trying to be calm about how I say it, careful about how I say it. But the reality is, nursing homes for decades have had regulatory requirements to stop the transmission of airborne illness from resident to resident. The idea that nursing homes don't understand things, that the collective consciousness of the country may have been hit with new terms like PPE and even I, who've been handling nursing home cases for almost a quarter of a century, realized probably in week 2 of this pandemic that I didn't know how to properly wash my hands until I, saw the YouTube video and started humming the national anthem while I sang and saw that, you got to get between your fingers and all of that. But nursing homes certainly did. And there are regulations directly on point that have been there for decades, since the institution of the Omnibus Budget Reconciliation Act of 1987, which is essentially our gold standard for the regulations pertaining to every nursing home that accepts Medicare and Medicaid, which is 97 point something % of them. Infection control is required. And that's not to say that there's not differences in COVID, and that there's not higher virulence, that there's not higher transmissibility than flu. And I'm really loath to even make the comparison, but the reality is, a year ago today, if someone called me and said, my mother died in a nursing home where a flu outbreak wiped out the entire population, resident population, and killed 45% of the residents there, I'd investigate that case. Not because, flu is an unavoidable thing, but because, or that I would necessarily be able to pursue the case. I mean, there are circumstances where you can't prove poor infection control. But if I just did my research and I followed the state surveyors, and I found that the place had years of infection control problems, and then found out that nurses didn't know how to don PPE, and that they went from one room to another despite an outbreak, and they never donned the PPE, never cleaned their hands correctly, then didn't report it to the local health department. And that outbreak went from one room to another room, and they didn't close communal dining, and they continued to have activities despite the outbreak, all the while letting visitors in and out, not reporting that information timely to the facilities, residents, visitors, and ultimately the health department. And 45% of the population got wiped out. Not only would I pursue the case, I would think it's one of the best cases I have, because these regulations governing nursing homes require them to have an infection control plan. They require them to have an infection preventionist, a person designated with additional training to prevent the outbreaks from happening and from getting worse. And that's 42 CFR 43.80. And I'm not going to read all of this. It's in my slides. I'm happy to send it to you. And again, looking at this list of participants, most of you know this like the back of your hand. But you're going to see things in these regulations that are, several years old that are now in the mainstream discussion for all sorts of businesses, unfortunately. But a system must be in place in a nursing home for preventing, identifying, reporting, investigating, and controlling infections and communicable diseases for residents, staff, volunteers, visitors, and independent contractors. And when you think about the kinds of things that this regulation requires, again, it's all in our collective consciousness now, but it should have been and was supposed to be in the collective consciousness of skilled nursing facilities for decades. A system of surveillance. Now, we hear this contact tracing and surveillance and these things in the mainstream media that are now applicable to a restaurant, but they've always been applicable to a nursing home. Identifying people who are ill, preventing people from transmitting illness from one room to another when your entire population has a coin flip chance of dying if they get the flu, much less COVID or something else. And by the way, this applied to Clostridium difficile infections, it applies to MRSA, it applies to influenza, and I would argue it applies to COVID too. Now, again, that doesn't mean you can solve them all. It doesn't, there's no strict liability here. Outbreaks happen, and it's sometimes never not the fault of the nursing home. But it is not difficult to to determine whether or not a nursing home has a role in that transmissibility outbreak surging. You still have all sorts of issues with specific causation and other things that I'll talk about. Again, the case is not easy. The collective mainstream media discussions about immunity right now have this, are painting a picture that all we got to do is sue and millions of dollars come flowing to us. And all we got to do is prove an outbreak happened at a facility and we win, and nothing could be further from the truth. As you know, anyone who's handled an infectious disease case in a nursing home knows proving that a specific nurse didn't wash her hands or didn't don PPE and transmitted this bug from your resident to, or from one resident to another resident, it's incredibly difficult anyway. Nonetheless, again, if you look at the regulation, you're seeing things like when and how isolation should be used for a resident, how to use personal protection equipment, proper hand hygiene, the circumstances necessary or the interventions necessary to ensure that bugs like this aren't coming from outside. And so the big myth and the thing that I think I want to dispel, and I think that we need to dispel, and ultimately we're going to be having these arguments in front of judges about immunity and about, what gross negligence is and what good faith is when you hear some of the immunity laws. I think it's really important that we get really well acquainted with the infection control regulations that were in effect for years before COVID ever happened, and understand and make sure that in our depositions moving forward, when we start seeing the COVID defense that I'm going to talk to you a little bit about as well, that we're not letting them get away with a narrative that said this was the most unforeseen thing and there was nothing we could have done, and that's why bed sores and broken bones and medication errors happened. And as we're going to discuss in a few minutes, COVID death cases, put them over here, because I think you're going to have immunity problems, and even if you don't, you're going to have serious hurdles from a proof perspective. The bigger issue for nursing home litigators is going to be how this immunity extends beyond COVID, and even when not immune, because remember, I mean, we're in the end of April. This isn't going away in November. In November, December, October, January, probably, even after the vaccine, COVID is now going to be threatening nursing homes this fall, next winter, probably the winter after that. And so there's going to be a million questions about how far these immunities go, but not only that, COVID is now in the collective consciousness. And so you're going to hear about this in every broken hip case, in every bed sore case. You're going to hear, oh, we had X number of COVID patients, because it's got such a visceral reaction with our communities. So I want to talk just briefly about the current situation and really what I perceive to be a very scary situation. And I don't think I need to say it to the people that are on this call. Again, looking at this list, I mean, I think everyone here are excellent attorneys. They know that the nightmare stories that are put out there to justify tort reforms and widespread immunities right now, like the Wall Street Journal hit piece 2 days ago, that say that we're all just circling, waiting to hit our heroes in the pocketbook for making Hobson's impossible choices with loved ones in this terrible epidemic. We all know on this call it's ridiculous. But I will also say, because it's this group, that you've got a really perfect storm. For anyone who's ever handled nursing home cases for more than a year, you know how regulatory action by states, surveyors, inspectors, reimbursement schemes, reimbursement strategies from ownership towards CMS, whether through Medicare, Medicaid, private insurance, TRICARE, whatever, visitor advocacy, ombudsman advocacy, and yes, civil lawsuits, how all of that works together to put an industry on a path that is much less likely to kill somebody through greed and neglect of their operations. And we're not talking about nurses here, we're talking about owners. And what we've got right now is walking into a relatively dangerous situation. What we've got is a bunch of regulations that have been rolled back for the pandemic. And again, I'm not saying that these things shouldn't happen, by the way. I'm just saying it's real easy to say, well, that's good because we're in a pandemic. There are going to be real consequences to people, real people who are completely vulnerable because of some of the things that are happening right now. The rollback regulations, again, they make perfect sense. I understand them. But they're going to have ramifications. One of them is that there are no more surveys going on right now. Regulators are not coming into nursing facilities and inspecting them. And if you file a complaint with the Department of Health or the Office of Healthcare Quality in Maryland or the Department of Health in Virginia or DC, what you're going to get is, yeah, we'll get around to you unless it's immediate jeopardy in the future. So even if you have an immediate jeopardy, a complaint that resulted in actual harm to a resident in the past, you're not going to have surveyors going into that nursing home. The only thing they're going in for is infection. And again, I understand why, but that's what's happening right now. And again, just like people are still going to hospitals for heart attacks and strokes, residents still need to be turned and repositioned or they're going to get gaping bed sores. And residents still need their medication timely and they still need to be fed and they still need to get their liquids or they can die from those things as well. I can tell you now, bed sores will kill more people than COVID in nursing homes this year. So some of these regulations make a lot of sense. Physicians visiting by telemedicine, I actually think that's one of the things that we're going to see come out of this long term. I think that the idea that doctors were reluctantly going in once a month because they had to physically go in once a month, I think allowing telemedicine may have them seeing these patients more. I actually think that might work out. Some things I'm a little more worried about, nurse aid competency certification waiver. That nurse aides, and again, I get it, nurse aides who are making $8 an hour are quitting in record numbers. They're just saying, forget it, it's not worth risking my life, I'm not going in there. I get it, I understand, there's a shortage now of aides. But taking away their competency certification, in any other circumstance would be a really scary thing for advocates like us. No ombudsman visits. So there's no advocates going in there saying, hey, you need to fix this problem, or you might end up in a regulatory problem, or I might tell my family to seek legal counsel or whatever, kind of the hammers that ombudsmen, when they go into nursing homes, have to try to influence better care, or calling care plan conferences. There are no care plan conferences other than through phones, which are, I just understand are just not happening. And there's waivers of all sorts of very important deadlines. Deadlines for MDS assessments and transmission to CMS. Those are the assessments to determine what the risk factors are for those residents and what they're going to do for them, what the care plan is going to include to mitigate against those risks. Pre-admission screenings are not required right now. There's there's waiver of deadlines on annual resident reviews and submission of staffing data to CMS. So the owners don't have to report to CMS anymore their payroll-based journaling staffing data that says how many people are in the building. So an unscrupulous owner, and I know it just is impossible to think that an owner could be unscrupulous right now, but an unscrupulous owner could get away with a whole lot less staffing and try to increase their profit margin if they chose to do that, when, quite frankly, you should be doing the exact opposite right now. So we've got rollback regulations as one of the things. We've got increased reimbursement. So more money is actually flowing into the nursing home as a direct result of the pandemic. So we've got decreased regulation. And I think one of the most important regulations that I forgot to tell you is the resident right to visitors is also suspended. Family members are not allowed to go into nursing homes right now unless it's a compassionate care situation. So an end of life situation, and then even then, only if they've not shown a temperature, they've been screened by the nursing home, showing no symptoms, and there is a room available that can be an isolation room where the person can say goodbye to their loved one in that room. There are a lot of people out there that are losing loved ones without being able to say goodbye. It's just heartbreaking, but also, again, to slow the spread of this thing, I understand why they're doing it. Increased reimbursement, getting back to that, proposed reimbursement for the next fiscal year is up 2.3% to 784 million more going to the operators. April 9th, 51 billion with accelerated advanced reimbursement payments going back to the skilled nursing facilities. 30 billion in emergency COVID stimulus funds from CMS went. As Chairman Verma said, the head of CMS, There's no strings attached to that money. They don't have to, the 30 billion. They can do what they want with it. And again, I'm sure many of them will use it to buy PPE and to put more staff on and to take care of their residents better. I mean, that's certainly my hope. Some won't. Some will take that money and advertise with it, or release a dividend or something else. CMS has issued additional guidance. I think you probably, again, know most of this, but they have to screen residents and staff now, temperatures taken at the door, no one in or out. They're doing essentially a reverse quarantine where it's more important to keep everybody out than it is keeping the people in. They closed all communal areas. Again, they should do that. Increasing the availability of wipes, alcohol-based sanitizers, and certainly proper notification to family members, as well as referring facilities. So if you send someone to a hospital right now with somebody who's got upper respiratory infection and a fever, it's very important that you're communicating that to the receiving facility so that they can take their protections. So let's talk about really quickly how they're doing. I know I'm already behind, right? So they're not doing great. So they only have infection surveys right now. So that, again, there's no surveys for turning and repositioning and pressure sores and falls and broken bones and all that. All the surveys, inspections right now are for infection control. And during the week of March 30th, there was a nationwide survey snapshot, basically, to see how we're doing. And what we found is that 36% of facilities were cited for improper hand hygiene among staff. And I want to just pause for a second on that, because I think it's really important that we kind of understand what we're talking about when we say 36% of the facilities were cited for improper hand hygiene among staff. This is the equivalent of somebody coming to you and saying, I'm the sheriff in your town. I know the path you take to work every day. And I'm going to be sitting on the bridge on the way to your job tomorrow morning at 6 a.m. with my radar out, ready to track your speed. And they tell you that that's what they're going to do. And then you blow by it at 100 miles an hour at exactly 6 a.m. the next day, and he pulls you over. That's the equivalent of what we're talking about here. These are not reported by somebody. There's no one to report them. This is not one nurse reporting another nurse. This is not certainly any visitors' complaints, because they can't see because they're not inside the facility. This is literally surveyors are going into the facility and observing in front of the staff that knows they're there and knows exactly what they're looking for, knows exactly why they're there, because they can't survey do anything else right now. And over a third of our nursing home staff can't wash their hands right before they go and they change a diaper, take care of a bed sore, feed a resident, and then go into another room, take care of another resident. 25% did not use PPE correctly. And that's really important, because I'm not talking about, because all you hear about right now in the news is these supply chains and can't get PPE and people are having to use masks over and over, and that's all horrible stuff. And no reasonable attorney is going to go suing a nursing home who could not get PPE due to interruptions to the supply chain in a global pandemic. And the suggestion from chambers of commerce and the nursing home industry lobby that we would is ridiculous, and everyone on this seminar knows that. But 25% did not know how to use PPE that they had. Is a very big difference. That's a big problem. And again, this is not somebody reporting someone else. This is a surveyor says, put on your mask. And a quarter of our staffs can't. Put on your gloves. Take care of a resident, take those gloves off, put on new gloves, and a quarter of our nursing home staff can't do it in front of them while they know they're there to judge them on it. That is a training issue. That is an issue with how ownership is operating the facility. That's not even the nurse's fault necessarily, or the aide's fault. That is, you have not been trained. That was the week of March 30th. March 30th. Thousands were dead. Kirkland was practically shut down. You know, nursing homes, stories about nursing homes, including piling bodies in sheds in New Jersey and whole staffs and resident populations being wiped out by this virus, were all over the place by that point. And 36% didn't know how to wash their hands, and a quarter of them didn't know how to put PPE on correctly. So here are my bold predictions for the future before I can get into what I think we're about to look at with immunity and I think just general strategy for us as we go forward. Some good facilities are going to have outbreaks, and some facilities are going to have outbreaks and problems with getting PPE because of interrupted supply chains. And whether there's immunity or not, you're not going to be able to assume already. There are going to be outbreaks that were caused by asymptomatic people. The nursing home took temperatures of everybody and documented it, and monitored people and did everything they were supposed to do, and it still got into the facility. You're going to see ultimately, however, that, and again, we're in the middle of it right now. This is like saying, trying to assess the damage from a tornado while being in the eye of it. A year from now, we're going to have so much data. We're going to have a ton of data about which nursing homes got hit by COVID, which ones had massive outbreaks, which ones lost 35% of their nursing home population and some staff members, and which ones had isolated outbreaks or no outbreaks at all. And I'm telling you, you can come back and hold my feet to the fire on this 1 year from now. The statistics will eventually show us that the number and severity of outbreaks will be the greatest at the lowest staffed and worst trained and lowest resourced facilities, because that's what it's always shown us relative to flu, C. diff, MRSA, scabies, every other kind of outbreak there can be in the history of nursing home litigation. It will eventually, yes, those things happen at good facilities too, but there's no doubt about it that it happens more at bad facilities, poorly operated facilities. My prediction will be you will see correlation without a doubt. Infection control problems before the pandemic, with flu, MRSA, the rest of it, will be a highly predictive indicator of infection control problems during the pandemic. So, ultimately, what does all of this get us? It's going to get us a lot of immunity. I will just briefly touch on it. DC, Virginia, Maryland, it's all kind of different, but quite frankly, very similar. Virginia actually just had another order come out right before I got on with you guys here today about the governor clarifying that 801, 22501, and 02, which are the immunity statutes in the case of a catastrophic health emergency, clearly apply to healthcare providers during COVID, which doesn't surprise anybody, quite frankly. The governor went a little step further just to clarify. He said it was to clarify. I think in some ways it made it more confusing, but he basically, pointed out that there is shortages of supplies, that things are being burdened, that health systems are being burdened, and that there will be immunity essentially for people affected by those supply problems, by those staffing shortages, by those things when COVID is the reason for it. And that's important, when COVID is the reason for it. And what this immunity really provides in Virginia is immunity for the COVID deaths. At least that's our perspective. I mean, I think I've been on BTLA today and there's been a lot of back and forth about it, but I think that the fight is going to be defense lawyers saying everything is covered. So a bed sore at a nursing home that had one COVID case is immune. I don't believe that's true. I believe that's going to be the fight, though, and I think that's where we're going to have the battle. Maryland is an interesting one. It basically provides for, under 14.3A06, immunity if the healthcare provider acts in good faith during or under a catastrophic health emergency proclamation. That's I don't love the wording of it, to be honest with you, because we are clearly under a catastrophic health emergency proclamation. If immunity is provided to healthcare providers if they act in good faith under a catastrophic health emergency proclamation, that would suggest that a routine medication error where a nurse gives 50 milligrams instead of 5 milligrams and kills somebody, completely unrelated to COVID, might fall within that immunity. MAJ is right now pulling down the legislative history of 14.3A06 to try to clarify some of that. But these are the kinds of battles that we're gonna have. I unfortunately for DCTLA, and I know the least about DC because at my last stop in my research, what I saw was that DC Council expanded 72301D, which already granted the power to the mayor to grant immunity to healthcare providers except for gross negligence and solely for the duration of the emergency. The new language grants power to extend it to, quote, any persons. From a nursing home, lawyer's perspective, that healthcare provider was enough. But I think that's the concern. I don't think that those immunities, I don't think Mayor Bowser has actually granted those immunities yet, to my knowledge. But she certainly has the power to, and I suspect that she's going to. I think, like I said at the beginning here, I think there are probably people on this in this seminar who would be able to speak better to the current legislative or emergency declaration of immunity in DC even better than I would. But you're seeing the same pattern. The way it's in New Jersey and it's in Pennsylvania, it's all variants of the same thing. We're going to, if you want to pursue a COVID case, you're going to need to prove gross negligence or some kind of increased culpability beyond regular negligence. You're going to have to prove lack of good faith. And, there's a million questions that are asked, that are kind of brought out by all of this. And of course, Maryland medical societies and lobbying groups and insurance lobbying groups are coming out of the woodwork here. And they are, if you saw the Wall Street Journal op-ed piece, it was absurd. If you see the letters that are actually being sent to legislatures and governors right now, you're going to see things like this from the Maryland State Medical Society that wants complete immunity from any administrative sanction, criminal, civil liability for any injury, death, alleged to have resulted from any acts or omissions in providing, arranging, delaying, withholding care during the current COVID state of emergency, not in dealing with a COVID patient, in the emergency, absent a showing of wanton misconduct as measured by a standard of care that incorporates all the circumstances of the emergency. Can you imagine having a conversation in front of a judge about that, about what they're suggesting, should happen here? I think that there are reasonable immunities, and I'm certainly not somebody who says no immunity should be granted, but the standard of care already incorporates a same or similar circumstances. Every med-mal jury charge, I think in just about every state in the union, has that the provider acts as a reasonable healthcare provider under the same or similar circumstances already. You're already, if something goes wrong during this pandemic, going to be in the context of the pandemic. These statutes were not, and I'm talking more about Maryland, these ones where the mayor or the governor can just, by executive order grant it are even weirder, than they seem more constitutionally suspect in some ways. But when you look at things like Maryland with the legislative ones, you can see that they weren't designed for a nursing home in a pandemic, where a nursing home already does the very things that they're required to do every day, every year for influenza and all the other ones. The immunity statutes really do appear to be focused on those situations where a healthcare provider is put into a situation that they would have never envisioned themselves being in. And it makes sense in that context. And the example that I've given in a couple of other speeches I've had or discussions I've had is when a tornado hits, a town in Kansas, and the neonatal nurse and all the other nurses are called to come to the town to try to help their citizens, their neighbors. And the neonatal nurse rushes in and has never done anything orthopedic and has never put a tourniquet on and has never treated anybody for that. It hasn't done anything like that since nursing school in one chapter of one book, but she's a nurse and she was called to the scene. And she gets there and you know, Mr. Smith's leg is popped out of his skin and she tries to fix it or put a tourniquet on it and doesn't do it right and something bad happens. She should be immune from that. We talked about a lot of, we heard a lot about ventilator rationing. And you know, to my knowledge, thank God, there hasn't been a documented case of that yet. But certainly if you were in a situation where, you know, an emergency room physician was put in a position of having to decide whether or not a 35-year-old mother of 3 was going to get the ventilator or the 90-year-old nursing home resident was going to get the ventilator, and they had to make that impossible, horrible choice because of the situation, yeah, immunity would probably be appropriate in this situation. We shouldn't Monday morning quarterback that decision for the doctor. But that's not what we're talking about here. We're not talking about, and I put in here Kobayashi Maru for any Star Trek fans that are out there, you know, the impossible decision, impossible task of taking care of somebody, where there's just literally more patients than the equipment can handle. That certainly makes sense. Or medical providers being put in positions where they're having to do something that they never intended to do as practitioners of that discipline. So, you know, should a nursing home be immune under certain circumstances? I think so, but I think it's much more limited than the way they're getting lumped in with a lot of other people. So we're going to be arguing, and some of the questions that are posed here is that, you know, are they immune only for COVID-related claims? Are they immune from, you know, if their resources were impacted? Does that extend to non-COVID cases? You know, if staff members quit because they were just scared of COVID, even if it wasn't in their facility, can they now claim that their low staffing level that resulted in not enough people to turn and reposition is immune in somehow? I can tell you whether or not it ultimately becomes immunity, widespread immunity, it will absolutely be a defense. You're going to see the defense. What's really unbelievable, I think, is you're going to start seeing defense lawyers raising the defense of low staffing levels. And I know for anyone who's done this for more than a month, that sounds impossible. But if they can actually demonstrate that a third of their staff just quit because they were making $8 an hour and they weren't going to risk their life to come in and change bedpans, and so all their nurse aides quit, even with the relaxed regulations and the competency restriction lifted for aides, I could see a scenario where they actually use it as a defense. And then, of course, lastly, how is things like good faith and gross negligence going to be interpreted within the context of COVID? You know, CDC and CMS have given, you know, increased guidance. If you disregard the guidance, are you acting in good faith? Again, like I think I told you at the beginning of this thing, there's a lot more questions than answers right now. And again, I'm happy to come back and talk about answers as we get them. But right now, I think what's most important is that we start to orient ourselves as nursing home litigators to essentially a new world and the COVID defense. You are going to see, and I think, you know, we've always seen defense lawyers try to make the argument that, you know, these nurses are hardworking caregivers and they love their patients. I mean, if you've ever been in a deposition with one of these cases and you've spent the last, you know, 4 hours ripping a nurse apart for her poor documentation or her inability to go to the doctor or to report a significant change in condition or whatever, you always see the redirect from the defense, which is, you know, why did you get into nursing? And, you know, and the dance of, because I love people and I love taking care of people and I held their hands. And you hear these wonderful stories, whether they're, you know, accurate or whether they're defense, you know, created, they're compelling when you hear them. Well, I can tell you the one thing that I'm quite certain of is if you didn't know it before, you know it now. Nurses are heroes. So COVID defense is not just going to be we didn't have enough staff, we didn't have enough resources, we didn't have enough PPE, the supply chains were bad, how could we have possibly envisioned that? I was too busy saving lives and risking my own to document. You're going to see all of that. That is going to happen, and you're going to see that for 3 years. You may see it longer than that. If you aren't ready for the COVID defense in a year from now, you shouldn't be in this. Whether you've gotten past immunity, whether we've laid all the groundwork that a bed sore case during the pandemic is not immune or is immune under certain circumstances or whatever. We'll get through all of that, but the COVID defense is here to stay. I can tell you that now. And that brings you to, well, how are we going to get around it? I'll tell you, and I think you can have an entire seminar. I think you might have an entire day-long seminar at some point about how to defeat the COVID defense. But I can tell you what my initial formulations and what my department is starting to already start to work on is getting back to what this litigation practice has always been about. It's never really been about nursing malpractice. I am not a nurse malpractice lawyer. I am a nursing home neglect attorney. And that really has to do with the business operations of a nursing home and not about the nurses. And I think that you're going to really, really need to adopt that, grab that, and own it in the next 5 to 10 years in light of the way the juries are going to swing. Because, a year ago, you walk into a nursing home, walk into a jury courtroom, and you say to a jury, this nursing home neglected my client and cared more about the money than them, and the place stunk, and there wasn't enough people, and the people that were there were mean and horrible, and my lady suffered a horrible death because nursing homes are terrible. And they just nod up and down with you like, yep, you're going to have some serious issues coming up with normative beliefs of your jurors. And in jurisdictions like DC and Maryland, where voir dire is essentially non-existent, we're going to have some really big issues that we better get our hands around. It is definitely going to be worth focus grouping these issues. It's something that I absolutely intend to do. But my basic point about how to defeat COVID defense, not the immunity, but the defense, although some of these arguments will overlap, is that you're going to need to get the heroes on your side. If you have not been somebody who went out, and we have not, I'll tell you that I personally have not been somebody who beats the pavement hard enough to find former employees, it's time. It's time to start making sure in discovery, if somebody's no longer an employee, that you get that information and you find that person and you get to have a conversation. People will leave these facilities now because it literally threatens their life, not just gives them a miserable day. And if you're going to take a case where, again, we're assuming we're past immunity, where the defense is going to be, yeah, but we're all heroes and, there was COVID in the building. You better have nurses that are on your side. You better be able to make a case that ownership left them out to dry too. I mean, think about how different it is if you're bringing in nurse after nurse after nurse to tell them that they did a crappy job in the middle of a pandemic, versus having nurse after nurse after nurse come up and say they were left in a no-win situation because ownership just would not give them what they needed. And it wasn't because of some outside supply chain, it was because they were greedy. If you can prove corporate greed, it's even worse in a pandemic. How have you all reacted to the stories of people selling bottles of water for $10 or bottles of sanitizer for $300 on Amazon? We all cringe. We all are horrified by it. If you can show corporate greed in a nursing home where they had knowledge of an increased vulnerability to those people, and understood that they didn't even care about their own staff members when they made their corporate greedy decisions. Oh, and by the way, got stimulus money and PPE money and increased reimbursement from CMS money, all at the same time that there were no visitors, no advocates, no regulatory coming into their facility. And this is when your resident got the giant gaping bed sore through her body. You're in a much better situation than if you're trying to sit across from sweet Nurse Smith, who's crying about how she had to go home every night to her family after risking her life to take care of your 90-year-old client. I mean, it's just common sense, quite frankly. We're going to want to follow the formula that we're all doing right now on our couch every night when we watch the news, when we're watching CNN, or we're watching these Trump press conferences, if you can still watch them. And it's, what did people know? When did they know it? And what did they do with the information when they got it? And I'm not just talking about COVID. I'm talking about when they start to defend themselves on, we couldn't turn in reposition, we didn't have enough staff, COVID did this, COVID did that. When did you know about this? What did you do about this? They can't just sit back and say, Well, yeah, I mean, we got the CMS alert on February 28th that said that nursing homes had to start coming up with their pandemic response plan immediately. And I had the CMS fact checklist of what we were supposed to do. And I had a person that was supposed to be identified as the interventionist, and I was supposed to bring my staffing coordinator in to come up with a plan to anticipate shortages in staff. And here's what I did to try to prevent it. If they don't have any answers to any of that, and they just took increased money, had no oversight, had no visitors, had no regulatory coming in, and they just allowed their people to rot in there. So because they knew they were going to get immunity and they were going to get, you know, hero status, and so they weren't going to be able to get hit. I think we have to go after them. You can't fall into a med mal trap anymore. I mean, we never could. It was never good for us to be in a med mal trap where we're trying to argue that a nurse deviated from the standard of care. You have to dot your I and cross your T, but you always needed to be successful at this to demonstrate that the nurse couldn't do her job no matter what, because she wasn't educated well, she wasn't trained well, she wasn't paid well, she wasn't treated well, she wasn't given what she needed, she didn't have the aides and the support staff she needed, and she didn't have ownership support, she didn't have a good director of nursing, she didn't have good administration and allocation of resources. She was in a no-win situation from the beginning. If you can make that case now in the context of pandemic, and you can lay down that kind of reptilian, you knew this was going to be a really difficult thing. Did you just continue the way you were doing before, or did you step up as an owner to protect your residents and your staff? Because you've had 3 years of poor infection control citations before COVID. You know, those kinds of things are going to be really important, I think. So the bottom line is focus on ownership, not the nursing home. I have gone super way over. So let me ask anyone if they have any questions, and if anyone needs to jump off and did not plan for 50 minutes, plan for 30 like I thought I was going to do, you certainly can email me, you can call me. I'm happy to chat about any of these issues. I actually owe some phone calls to folks that I know want to bounce these kind of things around with me. I see some comments here. I just want to take a look at some of them. Yes, John's correct. And Maryland just announced that they're going to test all staff and residents of nursing homes. Nursing homes are, by CDC guidance, we're supposed to be at least taking temperatures. Now, it's not the same as doing COVID tests, but we're, and I think, John, I think they're doing the antibody test. I don't know if they're doing the full, you know, giant spear up the nose test, but I could be wrong about that. I'll have to go back and look. Yeah, I think, Sydney, I think you're absolutely right. Your comment here that there's a huge issue with communication. There's a huge issue. I mean, they can't talk to their loved ones. A lot of these folks are demented. They have dementia. They can't use FaceTime. I mean, it's nice that we talk about that, and we do try to do, you know, you can try to do whatever you can to have some communication, but this is a lot of people you can't have communication with because of their underlying conditions. The biggest complaint I'm hearing right now is, and not just from the people I represent, but from, you know, I'm a member of the Consumer Voice, which is the large advocacy group. I've been on a bunch of their calls, and what they're getting is that there's just no information. That future care outbreak in Maryland, if you look at the news stories, what the families of the deceased are saying is, I found out from the news. I found out that my mom died from the news. Like, that's crazy. And if staffing shortages exist, and Sydney, to your point, I think a great thing to ask in one of these things is, are they accepting new admissions? I mean, when their staff got, you know, like, because I think what you're going to see is people are going to quit. There's going to be some people that quit. And so if some people quit and they you know, 2 or 3 staff members leave, A, did they try to replace them? And B, did they take new admissions? You know, they're going to try to make this story like we were working on a skeleton shift, and the only people who were there were the heroes who were willing to stay behind during you know, in the war zone when everyone else fled and retreated. That may be true in some circumstances too, by the way. So I want to be very clear that there are going to be cases where you just want to run away from them. You don't want to take them. I've already gotten calls about some cases that I would never want to even look at. You're going to have to be really careful about taking a COVID case. And I think you're going to have to be really careful about taking cases in January, February, March, April, May, June, July of 2020. How far is that going to go, though? Because the fall is going to be here and you're going to see it again. COVID's not going anywhere. But I do think we need to start wrapping our heads around it. In the cases that you, Pete Anderson asks, in the cases that you take, how are you going about investigating them? So right now, because I'm still pretty unclear about, the immunity situation. I mean, I don't think we totally know yet. By the way, we haven't even thought about a federal immunity coming out yet. And there's a lot of, I mean, McConnell's already talking about certain immunities in this next stimulus bill. And I know he's talking more about employers, but nursing homes are employers. So there's just a lot of things that are still kind of up in the air right now. I am looking at COVID cases. I am not filing a COVID case right now. There's no way in the world I'm doing it right now. Quite frankly, because I don't even know if you can prove one. You know, Pete, as you know from doing this work, specific causation on an outbreak case is really hard already. You know, I mean, if you have to be able to isolate where your resident got it. And that is just not easy. Even if you can prove that the entire facility got a ravaging outbreak and it was from a mistake from, you know, somebody being let in that shouldn't, it's can you get to your resident and basically prove that that's the only way they could have gotten it. And that becomes really challenging. It's really hard in flu cases. It's really hard in MRSA cases. So, you know, I think they're going to be uphill battles. And to your point, Pete, the fact that you even have clients right now that are in the facilities that can say, I saw somebody not washing their hands and taking care of mom, or she went from one room to the next. The truth of the matter is, these cases aren't going to go real well without whistleblowers, and that's the problem, is you got to make these decisions about whether you're going to actually file the case or not to get discovery on these things. I suspect if you try to file a demand, you know, put a demand letter on somebody, again, I wouldn't do it now, but if you do it, I think you're going to get, come and sue me. I mean, you know, it's like Maryland, I think you're going to have a hard time getting a CQE. You know, the whole thing is going to be really challenging. I will tell you, I am not that I would never handle a COVID case if I could get around the immunities and I thought I could prove specific failures of infection control and specific causation to my client. The much bigger issue we're all facing for those of us who handle these cases is, how is this going to impact our normal cases? That's really the bigger issue to me. If someone came to me and said, you can't sue over COVID, I will tell you, I think people are going to die from COVID that shouldn't in nursing homes because of poor infection control. If that's though what ended up coming out of all this was that you couldn't bring those cases, I think it would be really crappy for those families that could really prove that. But the bigger threat right now is that you cannot give some of these owners and operators that much room without regulation, without regulatory, without a civil lawyer looking at them, potentially holding them financially accountable for their staffing decisions, their resource allocation decisions, their hiring decisions, their training decisions. You cannot I'm thinking of some of these facilities right now, like, you know, Envoy and Consulate and some of these places that, yeah, you just cannot, you could not allow them to do that. Let's see. Eleanor said, who seemed really optimistic until just now. Yeah, Eleanor, look, the best way I can put this is that I'm not going anywhere. I've been suing nursing homes since I came out of law school, and I'm never going to stop. I'm going to spend the rest of my life holding them accountable, and that is not just in lawsuits. Like I said, I belong to advocacy groups. I am happy to help on legislative issues with like immunity, and I will do it public relationally if I have to. There's still going to be a place for nursing home lawyers to protect the elderly, and we're going to navigate whatever it is. I'm not optimistic that you're going to be able to just file lawsuits against nursing homes for every COVID death, nor do I think that we should. I think you got to be really selective with those. But yeah, I don't think that me or any of the other members of you know, DCTLA, MAJ, VTLA, AAJ, anyone who does nursing home stuff is just going to say, okay, well, now I'm done holding nursing homes accountable for abuse and neglect of the elderly. I mean, I, I'm doing this for the rest of my life. I know a lot of the folks on this list are going to do this for the rest of their lives. And so I don't have much of a choice but to be optimistic. It's going to be a fight. It's going to be new battlegrounds. There's going to be fights over good faith. There's going to be fights over, what is related to the emergency proclamations. Where does the immunity end and where doesn't it end? And whatever it is, we're going to have to pick up our swords and do battle, because without us, these nursing home operators can just run free, which is why they're all writing letters to all the governors and all the legislatures right now going, you got to give us blanket immunity, poor nursing homes, poor nursing homes. They're not going, oh, by the way, we've always had regulatory requirements for infection control. And oh, by the way, we'd be fine with you just limiting it to COVID outbreaks when we don't have enough PPE due to supply chain failures. They're asking for blanket, wide open immunity for the entire period of COVID, which is, according to Dr. Fauci, still going to be years and years into the future. We have to battle them, in the courtroom and in the court of public opinion, in the legislature. We got to fight them on every front, because quality care for these folks who can't defend themselves cannot be something left to the ownership of a nursing home. Can't. Eleanor, I won't tell you not to file. I'll tell you that stay fired up by all means, but I would hold the case a bit. I think right now what's happening is people who are even putting stuff on their website about asking for. I mean, if you saw that Wall Street Journal, I think it just boiled my blood. And I wrote I circulated it on the National AHA Nursing Home Litigation Group. I'm happy to send anyone my response to it. Boils my blood, though, the idea that that we're just trying to take advantage of the situation when they're sending these letters that they're not publishing to anybody, saying that they should be released from all liability for anything that happens in 2020 is just insane. But I'll not get on my soapbox. Does anyone else have any questions or comments or concerns or anything? And again, I'm not going anywhere. If you guys want to chat, you want to shoot me an email or anything. I know I went way over. So
I'm going to pop in here, Joe. That was just fantastic. I mean, I don't even practice law, and I was fascinated listening to that. So I thank you for your enormous wealth of information. I see that there's still some questions going on. You can either stay on and answer them, Joe.
I'm happy to stay on as long as
Okay, I'll just leave the recording going. I'm going to mute myself, and everybody can stay on as long as they like. I just wanted to just take a moment and thank you so much. We're all clapping for your presentation. So I'm going to mute myself and let the questions continue. I'm recording this, everybody, so you will have this to look back at.
Thanks, Mary.
Thank you.
John, I don't know the answer to that question, but it is a good question. I mean, look, I'll tell you an example. So John's question is, do we have good analyses of business practices that led to bad results in earlier disasters? So we do have an entire litany of case law and, analysis of businesses who failed in Katrina or allegedly failed in Katrina. I mean, there was a lot of litigation about Katrina. And in fact, there's a lot of Katrina is like the thing that chambers of commerce and healthcare associations are all pointing to make the case that we're just waiting to pounce on the heroes on the front line of COVID to bring frivolous lawsuits against them because people got sued in Katrina. So, I do think that you can look at disasters and see, bad business practices that led to worsening of a situation. Every American citizen is sitting there right now, and again, looking at the administration, the Trump administration, or maybe they're looking at their own mayor in their state or whatever, and they're saying, what did you know, when did you know it, and what did you do with the information? And they're doing it 20/20 hindsight, and they're basically saying, it is fair or it isn't fair to blame this, blame that. Jurors are going to get very, very comfortable with looking at a circumstance and saying, hey, I remember that was a crazy time, but what did you know? When did you know it? And what did you do with it? I feel like they're going to be very comfortable with that. And again, I'm going to feel way more comfortable. I can't even believe this is going to come out of my mouth. I'm going to be way more comfortable in Virginia, where I get to actually have voir dire and sit down with a jury and be able to say, you know, what do you think about this? What is the responsibility of a nursing home during all this? Whereas, you know, DC, you know, they're going to get a sheet that's, can you be fair? You know, get up there, and you're not going to know what you got there. Which is why I think you really got to focus group this. I think we really got to find out what the consensus generally is. Yeah, Sid, I'm with you. I'll send you, Sid. I don't know if you saw the thing I circulate on the nursing home thing, but yeah, I think we're really being a little. This is Joe Musso, just me talking. Okay, this is nobody else. I think we're being too scared in a way here. I see on these listservs people just saying, let's just duck in a hole and, you know, let it blow past us, while all of these politicians and lobbying groups and opinion pieces in these newspapers are killing us before we even anything's going to happen, because somebody put on a website, you know, because some lawyer in DC or in Chicago put on his website, hey, if you lost a loved one due to negligence during the COVID, you know, you might have something for us to look at. Give us a call. And it was like, you know, that was the worst thing in the world. And I see lawyer after lawyer after lawyer coming up on our listservs saying things like, you know, I don't think you should be advertising. And again, all right, I get it. I understand that. And, you know, I think it leaves a bad taste, and we got to be really careful, and we got to keep our head low. And there's a part of me that just goes, you know, maybe it's the almost a quarter of a century now that I've been doing this. I have nothing to apologize for. You know, I'm not filing frivolous lawsuits. It is hard as hell to hold a nursing home responsible for killing or injuring somebody who is already so old, sick, frail, has no future, you know, wage loss, has no lost income, has no dependents. I mean, my job's already really, really hard to do. And I don't bring frivolous lawsuits. I got nothing to hide. And the idea that what we do is being twisted into some kind of opportunistic and advantageous thing, that we're just jumping into this. I mean, everything, I talked about the contingency fee agreement. I saw a comment on one of these Facebook things that about the contingency fee agreement. I said, I feel like a lot more people should have that as their business model. I mean, imagine going to a surgeon and saying, you know, hey, it'll cost $5,000, but I guarantee you're going to get better. And if I don't do it, you're not going to have to pay me. You know, I feel like there should be a lot more of that. Any other questions, concerns, issues? Let's see. I think that's it. If anyone needs anything at all, please don't hesitate to reach out. You guys know where I am. I'm over at Ashcraft and Jarrell. I'm easy to get a hold of. Please call. I'd love to just even roundtable it with you. Like I said, even if it's not just to ask advice, just to help me come up with strategies. I think that's what we have to do. I think we all have to get in the lab, break out all the issues, put them up on a board or something, and say, hey, how are we going to deal with this? Because again, it's just, there's no option of leaving our elderly stuck in these nursing homes getting hurt because of COVID. That just can't happen. Thank you so much, everybody. I appreciate you listening to me drone on for this long. And take care. Bye.
Thank you, Joe. Goodbye, everybody. Thank you for coming to the meeting. Take care. Stay well.